Now I'm going to go to the next R, which is reuse. The worth of disposable medical devices is roughly around, industry is around $50 billion, and it's rising at a rate of around 4% per year. Blood pressure devices are routinely used as reusable devices because they are considered as low risk of infection. Reusable devices generate carbon footprint because of the labor cost to clean them, as well as because of the number of wipes you use. Now, if you use one reusable device on multiple patients versus using only one reusable device on one patient, that will have implications because how many times you will have to clean it. Disposable devices are, of course, generating carbon footprint from production, transportation, and eventually incineration. So the author looked at 4 different scenarios. Scenario number A, which is in the office setting, comparing 20 patients in which they're using disposable blood pressure cuffs versus one reusable cuffs. Of course, no surprises there. Using a reusable cuffs generated far lesser greenhouse gas emissions by almost a factor of 40. Now, looking at the scenario number B, in ambulatory procedure settings, they compared emissions coming from disposable versus reusables on 10 patients. Now, 10 patients will get disposable cuffs, and now they're comparing it either with one reusable cuff or 3 reusable cuffs, one in pre-op, one in intra-op, and one in PACU. So when you use 3 reusable cuffs, your greenhouse gas emissions from reusables are still better, but the factor drops from 40 to almost 13. The third scenario is utilizing it in the inpatient setting over a length of stay for 5 days. So now the emissions are, of course, divided over a course of 5 days. If you're using a reusable cuff for 5 days, if you're cleaning it after each measuring reading, using more and more wipes, that will actually make reusable blood pressure cuffs less favorable, and that the factor difference actually came down to 2 to 3. Same thing happened in the ICU setting in the D setting, where they basically compared one reusable cups versus 20 disposable cups for length of stay in the ICU for 5 days. And they found that the reusable cups actually are better if they are only cleaned once after the end of 5 days on the patients. So in terms of costing, utilizing a disposable cuff in an office clinic setting is not a financially good idea. It will be costing 10 times higher than the reusable cuffs. Even within the ambulatory surgery procedure center, the savings could be either 10 times or 3 times, depending upon whether you're using one reusable cuff versus 3. In the regular ward setting, they actually never break even. Actually, disposable cuff was a cheaper option than using a regular ward because of the number of wipes it required. Now I'm going to talk to the next R, which is the recycling. Recycling honestly is a myth. But we'll talk about it. So this study was conducted by Cassandra Thiel in 2014. She actually did a study to evaluate greenhouse gas emissions coming from hysterectomy, utilizing 4 different approaches. And this study actually took one step further, which strategies will work the best in cutting down those emissions. So they looked at different scenarios. Under anesthesia interventions, comparing desflurane with nitrous oxide, sevoflurane with nitrous oxide, or a total intravenous anesthetics. Under material interventions, they looked at maximizing recycling, maximizing regulated medical waste reduction, maximizing the use of OR towels and surgical gowns. Under energy interventions, they looked at adding an occupancy sensor into the operating room, converting electricity to renewable sources. Anesthetic gases, if we do a better job in cutting back our fresh gas flows, replacing gases with the lowest global warming potential, or converting to TIVA, has the highest impact. 25% reduction in laparoscopic surgeries can happen just by changing the anesthetic choice. Now, if you do single-use devices reprocessing, that can lead to additional 10% reduction in your greenhouse gas emissions. Maximizing recycling, regulated medical waste reduction, only led to 5% reduction in their greenhouse gas emissions, because recycling is not the be-all, end-all solution for waste reduction. Actually, under the hierarchy of waste to reduce waste, recycling is very low in that list. The first number is always remove, not to recycle, because recycling requires a market. If I'm going to put something in the trash bin, is there a market for someone to take it and use it for other purposes? Now, the maximum benefit happened from utilizing reusable surgical instruments or using minimal materials. That has an impact of decreasing your greenhouse gas emissions by almost 50%. The last segment of my talk is about research. Implementing carbon tax is an effective strategy in addressing carbon pollution. So the study is done in Canada. The author actually, just like us, did an educational project in 2016 to remove desflurane from their ORs. And by 2019, they were able to remove desflurane from their ORs. Currently in Canada, there is a tax of 30 Canadian dollars per metric tons of carbon dioxide. If we apply the same tax on our anesthetic gases, it will increase the price of CO by $1.48 per bottle, increase the price of desflurane by $26. They are projecting this tax will go up in 2030 to $170, which will increase the price of CO by $8 and desflurane by $151, making it financially unsustainable to use desflurane. Currently, volatile anesthetic gases are not included in the greenhouse gas inventory or formulary to impose these taxes. But again, for healthcare institutions, it can be a strategy to force them not to use a gas with the highest global warming potential. I've heard from many of my colleagues, there is a unique advantage of using desflurane in obese patients. So this is a meta-analysis of randomized controlled trials, which actually did show that if you use desflurane, patients are able to open up their eyes faster by almost 4 minutes, and they were extubated also by 5 minutes sooner than sevoflurane. However, there is no difference in the incidence of post-op cognitive decline or the discharge of these patients from the PACU. Even under the ERAS guidelines for bariatric surgery, under the standard anesthetic protocol, it does not allow recommendation of specific anesthetic agent or technique. The only thing that got the highest recommendation was using an opioid-sparing anesthetics. Let's also have a talk about sevoflurane and compound A. So this is again a meta-analysis of randomized controlled trials, and based on the outcome of this meta-analysis, they found that sevoflurane does not contribute more to nephrotoxicity in humans than other anesthetics. And the reason is we are not comparing apples to apples. The studies were done on mice. Mice has increased activity of enzyme beta lyase in their tubular cells. That is what leads to generation of compound A. Humans don't have that enzymes. Millions and millions of anesthetics has been given. Not even a single case report of compound A has come from anesthetics. So based on this, they found that there is no association between the use of SIVO and post-op renal impairment as compared to other anesthetic agents. And therefore, the scientific basis for recommending higher fresh gas flows needs to be revisited. These are the ASA statement. And basically, they do acknowledge that FDA still recommends using 2 liters fresh gas flow, which leads to excessive consumption and waste of SIVO. So ASA has evaluated the scientific evidence and concludes it is safe to administer sevoflurane with fresh gas flows of less than 2 liters, despite the FDA warning, as long as we are using a weak base CO2 absorbent. So friends, I'm going to wrap up my talk here. So far we discussed about 2 different healthcare systems, US, where the emissions are going up, National Health Services, where the emissions have actually come down by 26%. We are also looking at recycling is not the solution because it has a very low hierarchy in waste reduction. Pharmaceutical waste is extensive and it is primarily determined by manufactured packaging sizes. We have no control over that. Manufacturers are incentivized to prepare drugs in multi-dose vials, larger vials, and also there is a lack of awareness among healthcare providers about how our actions impact sustainability. The concept of best patient outcome practices has to include optimizing resources and pollution prevention. And many countries are actually addressing it. For example, in Sweden, they have something called WISE list. Every medication label will demonstrate the PBT scoring, which is its impact on the environment. So physicians can do environmental preferable prescribing. We really need an honest discussion between our ID practices and also pollution prevention, because we need some sort of a risk stratification. These practices are becoming unsustainable. We know that the number of surgeries are increasing, so is the waste. Robotic surgeries actually generate 30% more waste than the regular surgeries. So teaching hospital generate more waste than non-teaching hospital because of the because of the teaching nature of the hospitals. So what we have learned from these is we can utilize the 6R model of waste reduction, remove what we can, reduce what we should, and reuse what we must, because we clearly have not made our healthcare sustainable. So clearly, creating less pollution is the only and the best solution. I'm going to rest my case. Thank you for listening.